This is Module 5 in Promoting Successful Rehabilitation Outcomes in Multiple Sclerosis. In this module, we'll discuss special considerations that we have to take into account when evaluating and managing patients with MS. The special considerations that we need to take into account include fatigue, which we've talked about before, but we'll spend more time discussing today. Temperature sensitivity, especially that heat intolerance, tremor and ataxia, which certainly gets in the way of motor control, cognitive dysfunction, bowel and bladder dysfunction, as well as respiratory muscle weakness. Let's discuss each one in a little bit more detail. First, MS fatigue. This is a subjective lack of physical and/or mental energy perceived by the individual or caregiver to interfere with usual and desired activities. We actually have two types of fatigue in MS. Primary MS fatigue, which is probably due to the impaired conduction of nerve impulses resulting from demyelination and axonal degeneration. We also have secondary MS fatigue. And secondary MS fatigue most often results from some of the other side effects or symptoms or the medical management of the MS. Sleep disturbances, which can result from spasticity or spasms in the leg, neuropathic pain, musculoskeletal pain from muscular imbalances, the presence of nocturia, all of those can contribute to sleep disturbances, and then obviously fatigue. Medication side effects might also be more stimulating to the patient and prevent them from getting a restful night's sleep. Deconditioning can be another factor, as well as extra exertion required for daily activities. We saw that displayed in early modules, especially with weakness and spasticity. Depression and certainly other medical conditions all can factor into the development of secondary MS fatigue. MS symptoms can be related and interdependent. So if the patient is depressed, that certainly could increase their fatigue. If cognitive dysfunction is present, that will also contribute to fatigue, just as spasticity or constipation can contribute to fatigue. All of these can interact on each other or independently cause the patient to experience more fatigue throughout the course of the day and have interruption of the sleep cycle. Other factors that aggravate fatigue include obesity, temperature sensitivity, and this is usually to heat. The thought here is that when an axon is warmed up, even a normally myelinated axon, there is a slowing or delay in the propagation of action potentials. So if we now have a demyelinated axon, and that axon is heated as a result of an increase in core body temperature, that will contribute to more delay of the propagation of action potentials. Noxious stimuli, such as a bladder infection, presence of a decubitus, certainly can aggravate fatigue. And we mentioned inactivity or overactivity, and other medical conditions may include anemia or hypothyroidism. Certainly, standardized measures are also important in the assessment of fatigue. Our patient Mike is displaying the 6-minute walk test, and as he walks for 6 minutes, the therapist will be recording the distance that he covers. In this clinical environment, a pathway is marked off 50 feet in length. So in this situation, the patient will have to have repeated turns once he gets to the end of the 50-foot pathway. However, as long as the therapist is consistent with using the same walkway or pathway, then the reliability of the data will be the same. For sake of time in this video, we've recorded the first minute of Mike's walk, and now we're looking at the last 45 seconds. And you might have an appreciation that he's starting to slow down in his swing phase, especially on that right lower extremity where he has most of his weakness and spasticity. And we'll notice as he's now walking towards us an even greater delay in his ability to initiate the gait cycle. Not unusual for a person with multiple sclerosis, when walking over 2 or 3 minutes, to start to begin to experience more fatigue as they continue to walk. So the 6-minute walk test has been demonstrated to be a valid and reliable measure of gait dysfunction and endurance in patients with MS. Well, how do we manage fatigue? That becomes an important factor for the therapist to take into consideration. Are there things that we can work with the patients to start to identify problems that they're experiencing? Starting off with the completion of a fatigue impact scale that helps us recognize the patient's self-perception of fatigue, discuss with the patient sleep problems that they might be experiencing, whether it's frequent voiding during the night, restless legs or spasms or spasticity in the night, or maybe that pain, musculoskeletal pain. Proper positioning during sleep might be helpful for the patient to have a more restful night of sleep. And don't forget to review the medications that the patient may be on that can contribute to fatigue. It is not unusual for oral baclofen to have a side effect of lethargy or sleepiness. Patients are dosed up to a point where the spasticity can be managed, but unfortunately, baclofen not only relaxes the spastic muscles, but all of the muscles, contributing then to fatigue. The energy management strategies which should be incorporated in rehabilitation should be focused on conserving as much energy as possible. If we know that spasticity is getting in the way, we need to get the patient on an exercise program that is addressing the spasticity, stretching the spastic muscles, strengthening the antagonistic muscle of the muscle that's spastic. We've looked at improving core stability as a means to address weakness as well as spasticity. The use of appropriate ambulatory aids so that the patient is not becoming more fatigued during ambulation because their balance is off, or they're struggling to advance their leg forward because of the presence of weakness and spasticity. Teach the patient different types of heat management strategies. Certainly participation in a regularly prescribed exercise program, which should be a combination of aerobic as well as weight training, can be advantageous in fighting this fatigue and conserving energy, as well as the appropriate prescription of ADL assistive devices and mobility devices, such as a scooter, which could be used in the community. Now we'll see a demonstration of an energy conservation technique. We saw Andy in a previous video and discussed at that time that he has weakness and spasticity predominantly on the left side, impacting the left upper extremity as well as the left lower extremity. He walks with the use of a wide-base quad cane, and without the device is very off balance. If Andy was going to be doing some work in his kitchen, such as making a pot of coffee, pouring the coffee, adding his cream and sugar, we'd like to have him in a seated position versus standing, because the longer time that he spent standing at the counter while he is challenged and struggles to try and open up the sugar packet obviously is going to contribute to more fatigue. This is actually a perfect example of referral for an occupational therapist to become involved in his care, to have an adaptive device to assist him in stabilizing that sugar packet while he uses his right hand then to tear the packet open. Just imagine, though, if he was standing at the counter versus sitting at the counter and struggling to do this task. He's now opening up the creamer, and unfortunately with the weakness in the interossei muscles in that left hand, he experiences the same challenge in opening up the creamer that he did with the sugar. But at least he's in a seated position, he's supported, his energy overall is being conserved, but certainly referral for an occupational therapist to assist in making that task much more efficient for Andy would be extremely beneficial. Let's talk about that heat intolerance. I mentioned earlier that when a normal myelinated axon is warmed up, that can slow down the propagation of action potentials along the axon. So in a demyelinated axon, increase in body core temperature in and of itself can contribute to further delay and slowing of the action potentials. 70 to 80% of individuals with MS are heat intolerant. Therefore, it is important for the therapist to develop strategies to avoid increasing the core temperature. And there are some simple things that we can do. Recommend to the patient to keep the environment cool between 62 to 66 degrees Fahrenheit. When active or on a hot day, to hydrate with cool liquids or popsicles or Slurpees. To wear lightweight, loose-fitting clothing, again in warmer temperatures or environments, as well as during exercise. And then the use of a cooling vest or garment, and there are several available on the market that can be used. They are ice cooling gel packs inside the vest or garment that can contribute to lowering the core temperature. Other strategies to avoid increasing core temperature, specifically related to exercise, would be to exercise in an air-conditioned environment. If that's not available, using an oscillating fan to promote body cooling, or exercise in a cool pool. Aquatic exercise or even aquatic therapy is very advantageous for individuals with multiple sclerosis, but caution should be taken with the temperature of the water in the pool. The other consideration certainly to recommend to our patients is that they should rest after activity and exercise. It is not advantageous for someone with MS to do 60 minutes consistent exercise without rest breaks in between each routine. And during that rest break, to take advantage of a cooling towel, having a cool drink, maybe standing in front of a fan to enhance the evaporation of perspiration from their skin, which will then help to cool the core body temperature. Another special consideration that we must take into account in multiple sclerosis is the presence of tremor and ataxia. Both tremor and ataxia affect up to 80% of the people living with MS at some point during the disease process. Let's discuss tremor first. Up to half of the patients with MS attending specialty clinics have tremor present. Tremor tends to result from demyelination of nerve fibers, now in those specific pathways that coordinate voluntary muscle movement. So these are the typical pathways we see between the cerebellum and the cerebrum, specifically the motor cortex. Intention tremor is evident as the patient is performing a movement. So any type of deliberate movement, we would see tremor superimposed during the volitional activity. Gross tremor can also be evident in multiple sclerosis, and this most often is displayed as a truncal tremor. The patient may be seated in a chair, and yet you start to see their trunk oscillating back and forth, or you might see tremor activity in the arms and legs. So in an upright, supported position, even without initiating volitional movement, gross tremor can be present. Ataxia is an involuntary muscle movement, frequently superimposed upon a volitional movement. Most frequently, in a clinical environment, we will describe this as dysmetria, or we might see it in dysdiadochokinesia, the inability to reciprocally move the upper extremities in supination and pronation. Ataxia can also involve flailing of the extremities, certainly that incoordination, and often a wide-base gait because of the difficulty the patient has in placing their foot exactly where they want it during stance phase. Most often, ataxia results from lesions, again in the cerebellum, just as we saw with tremor. It can also be seen with sensory impairment. So if the individual has involvement of the dorsal column and the spinal cord, interrupting the transmission of proprioception from the lower extremities up to the parietal lobe and the cerebral cortex, they don't have an awareness of where their feet are in place, and this can also result in ataxic-type movements. The other lesion can be present in the central vestibular section of the brainstem, another area, unfortunately, with multiple sclerosis where we see a lot of demyelination, and this was discussed in more detail in the module on balance when we talked about difficulty with ocular motor control and the presence of internuclear ophthalmoplegia. This is Mark, and during the examination here, we are going to first clear the range of motion of the joints and the muscles, perform manual muscle tests to make sure that there's adequate strength to perform coordinated tasks, and then we will see that Mark displays tremor and ataxia, which is going to impact his overall functional mobility. But when assessing for coordination or the presence of ataxia, the therapist must first ensure that there's adequate range of motion and strength to perform the task. If the patient has less than 3 out of 5 strength, they're going to have difficulty moving, but it may not be a coordination problem, but a problem with weakness. You can see that Mark's strength is easily 5 out of 5. Now the therapist is going to look at the upper extremities, and you just saw there on that left arm a little excessive movement when he went through elbow flexion. The therapist again is testing the strength, and the strength is absolutely fine, but there was some incoordination of doing elbow flexion. So now we'll test further. We'll do the test for dysmetria. The patient is cued to touch their nose, then touch the therapist's finger, and you see the presence of dysmetria with the proximal target, meaning when they touch their nose, as well as they reach out to the distal target, the therapist's finger. You want to do this 5 times, recording whether or not there's intention tremor, which is mildly present, and then their ability to accurately strike the target. Now the therapist has modified this task. She's shortened the range. Look at the improvement in Mark's coordinated movement when we shorten the range of motion. This is very important because this then becomes a treatment strategy for us. Shorten the range that the patient initially moves through, as well as slow down the movement pattern. Now we're going to look at supination and pronation, and you see the presence there of dysautokinesia. The left hand is unable to keep up with the right hand in that rhythmic alternating movement. To make sure it's not a problem with proximal stability, put the elbows at the side and ask for the same task. So we know in Mark we've got problems with coordination. We saw dysmetria, we saw some intention tremor on the left side, and we saw problems with alternating rhythmical movement with the supination pronation. Now we'll test the lower extremities, and we most often test the lower extremities by performing the heel to shin test. So the patient is asked to repeatedly take their heel to their ankle, then up to the shin, without dragging it along the anterior aspect of the shin. So he's got to accurately strike the top of the ankle, then the top of the knee repeatedly for 5 times in a row. There's some intention tremor as the patient performs that, again specifically on the left side, and then inaccuracy in striking the target. So how do we treat ataxia in tremor and MS? Well, we're going to go back to some of those same exercises we used in core stabilization. Using weight-bearing activities can promote increased proximal stability. If the patient doesn't have adequate stability or strength in the shoulder girdle or hip and pelvic girdle, it'll be much more difficult for them to perform a coordinated task with the distal aspect of the extremity, such as the ankle foot or the wrist and hand. In addition to the weight-bearing activities, taking the patient through a series of balance and coordination exercises, and then potentially prescribing for the patient the use of an assisted device so we can prevent any occurrence of falls. Supportive garments can be used at times to give more sensory awareness of the extremity, and we will see a demonstration of the use of light weights applied to the distal part of the extremity, again with the goal of promoting greater sensory awareness to the brain to assist in the output of motor performance for coordination. Now we're going to have Mark move into one of those weight-bearing activities, and again we demonstrated this similar exercise when we were talking about addressing weakness and spasticity. We also talked about the importance of core stability in our module on balance. So when Mark comes up to tall kneel, you see that little trunk oscillation there? So he does have the presence of a little trunkal tremor because in assessing his strength, his core muscles are absolutely normal. So repeatedly having him move up into tall kneel posture, which would be a way to increase weight bearing through the lower extremities, the hip and pelvis. And then if we kept him in quadruped, that would have put more weight on the shoulder girdle. Now we have him move from tall kneeling into half kneel. Here he's got a weight shift to the left, clear that right leg through, and notice the challenge that he experiences with that. The therapist is giving contact guard and occasional minimal assistance to help with control of the trunk. This is not weakness. This is trunk control. And you see some evidence of that instability, that trunkal ataxia. Left side is even greater to clear into the half kneel posture when he weight shifts on the right. He has difficulty holding his posture upright and bringing the leg back down into tall kneeling posture. Even when he brings that left leg forward, notice the difficulty he has in accurately placing it in a position where he can get stability. Now we're going to ask Mark to do a couple other core stabilization exercises. We saw the alternating upper and lower extremity arm and leg movement. So right arm, left leg, left arm, right leg, referred to as the bird dog, trying to ask for that core stability, that holding exercise. And again, the problem is not that of weakness, it is of trunk instability due to the problem of his coordination. Mark is going to move into a seated position for us now, and then we'll have him move over to the parallel bars so that you can see the challenge he experiences with walking. We have intentionally taken his assistive device away so that the therapist is very closely guarding now. You'll see the wide base of support, the very hesitant movement, the increase in trunkal oscillations, very kind of stuttered type of gait pattern, exaggerated heel strike, really not smooth coordinated movements at all. If we want to work on the ataxic movements, we don't want to challenge the balance at all. So we've put Mark in the parallel bars, hanging on with two hands, and now we're working on accuracy of movement. We saw that dysmetria, recall, in the examination. Notice that he has some difficulty accurately striking the three targets. The therapist is now applying a light weight, a 2-pound weight, to the distal extremity to add in proprioceptive feedback, awareness of where the leg is in space as he starts to sequence that motor control to move the leg and strike the three targets. There's no evidence to support the use of light weights in improving coordination. Clinical anecdotes suggest that it can be helpful, and it does take repeated practice with the patient. Notice some difficulty still with that left leg in accurately hitting the targets, but he's probably, if we measured him, he's probably a little bit closer than he was without the use of the light weight. And certainly you want the patient to visually focus. Use vision as another feedback in improving the coordination of the task. Because swing phase and placing of the feet is so important during the gait, having the patient repeatedly step over and back a cane or object placed on the floor can be another means to work on coordination for swing phase and stance phase. Notice the excessive movement Mark has in both lower extremities, the left a little bit greater than the right in attempting to clear the bar. In our movements of that particular task, we wouldn't have such exaggerated hip, knee, and ankle flexion. Another special consideration that we have in multiple sclerosis is cognitive dysfunction. Believe it or not, cognitive dysfunction affects from 40 to 70% of people living with multiple sclerosis. It can occur at any stage of the disease, and can also often go undetected. If the patient is not working full-time or is not challenged in their cognitive processing, it may not be picked up early on in the disease. Most of the problems that patients do have, especially early in the disease process with cognitive dysfunction, is what's referred to as executive functioning. And the easiest way for us to think about executive functioning is the ability to multitask, or even to sequence all of the activities that you'll do in the routine of a day. So patients who have multiple sclerosis and challenged with executive functioning will have difficulty coordinating their activity throughout the course of the day. If they have to get children up and off to school, then themselves ready to get to work, then get to work, and then go through various types of activities throughout their workday, all of these contribute to executive function. So the skills necessary for purposeful, organized, goal-directed behavior, including that planning activity, the sequence of the day, being able to self-regulate, adjust to changes that might occur throughout the work schedule or home schedule with the children, and then appropriate response to feedback if there is a change in the planning or activity for the day. Executive functioning does involve memory as well as the speed of information processing, the individual's ability for mental flexibility, that multitasking component, and then the ability to attend to and concentrate on the activity that they're undertaking. When there is the presence of cognitive dysfunction, we need to adapt our therapy program for the patient. And certainly one thing is that we need to be sensitive to the fact that they may have difficulty in processing information, may have difficulty in planning their daily schedule. So the patient may arrive to therapy on the wrong day, or they may forget the time of appointment, arrive an hour early or an hour later. When the patients do experience cognitive dysfunction, the therapist has to be flexible to this and potentially use other factors to assist.